the JAMA Network.
My name is Dr. Joanne Elmore. I'm a professor of medicine and epidemiology at the University of Washington in Seattle and an affiliate investigator at the Fred Hutchinson Cancer Research Center. In the U.S. alone, 1.6 million women every year are undergoing breast biopsies. These are challenging to interpret, and the goal of our study was to evaluate the accuracy of doctors when they're interpreting these biopsy tissues. Our study included 115 doctors from across the U.S. and 240 biopsy slides. Each of the participating doctors, we gave them a box of slides, 60 cases, and they would interpret these biopsies on their own without knowledge of anyone else's interpretation, and they sent the results back to us. We then compared their diagnoses to those of a reference standard developed by a consensus of very experienced breast pathologists. I should add that these are pathologists that are actively interpreting breast tissue in their own clinical practices. They're from across the U.S., and they kindly donated their time, 15 to 17 hours, to participate, which I think is a reflection of how committed they are to this topic and how we all want to try and do a better job. When the case had invasive breast cancer, there was near perfect agreement on the diagnosis. So that was very reassuring. When we got into the diagnosis of ductal carcinoma in situ, or DCIS, while 4 out of 5 cases they agreed with the diagnosis, this also means that 1 out of 5 times they disagreed. They either overinterpreted or underinterpreted those cases. When we looked at the cases of atypia, and this is cases such as atypical ductal hyperplasia, we actually found about 50% agreement among this very large group of U.S. pathologists. Limitations included the fact that it was a testing situation. It would be impossible to take such a high number of test cases and secretively insert them into clinical practices of doctors across the country. So it was a testing situation. We also only had 1 slide per test case, and in clinical practice, the doctors may have multiple slides per case, and they sometimes could have perhaps more clinical information. We were surprised by the amount of disagreement among these doctors. We hope going forward we can try and limit the number of breast biopsies that are done. When we do have breast biopsies, we probably need to realize that there may be some cases in which we will have a hard time coming up with a diagnosis. The variability and the disagreement we found among these pathologists is not unique to the field of pathology or to the field of breast pathology. Similar amounts of variability have been noted in radiology, among breast imagers, in cardiology, in internal medicine. So this is not unique to the field of pathology. I'll point out that even the experienced pathologists in our study, they had a hard time and they disagreed with each other on the diagnosis of some of these cases. We now realize some areas where we really do need to do more work. We need to investigate the potential for molecular markers to try and improve our ability to come up with an accurate diagnosis. And we need to consider, now that we can digitize these slides and come up with a digital image, let's see if the computer-aided detection programs can be developed to help us. We all care about women. We all care about their breast health. We want to give them the best diagnosis possible. We've identified areas that are really challenging, and we as a team want to try and do a better job.